have, it is having very high level of the beta cell compromisation. It may be almost 2/3, 66% to 80 to 85% maybe. So new performance measures has been proposed. Intervention in women using a blood glucose level of either 135 milligram per deciliter or 140 mg per dl is recommended. So as per this fact, 135 and 140 is also not acceptable. There should also be the intervention required. Now come over to the diagnostic criteria based on the HAPO study. HAPO study is one of the biggest study which has come up in the recent years. About 23,000 something patient has been included in this study, and in this particular study, patient has been studied on the different level of the hyperglycemia. And we have tried to get the answer of many unanswered questions through this HAPO study. OGTT is resource intensive. Due to this, many health services do not test hyperglycemia in the pregnancy. So we need for a simple economical and evidence-based test. Randomized controlled trial shows benefit of treating gestational diabetes women identified primarily by post-load values. There is no high quality evidence that women and their fetuses benefit from treatment if only the fasting value is found abnormal. Now come over to the criteria which has been developed on the basis of the HAPO study, and that criteria was the IAD-PSC criteria. This criteria says fasting plasma glucose cutoff should be 92. 1 hour for a plasma glucose after 75 gram glucose should be 180 or less than that. 2 hour plasma glucose after 75 gram glucose should not be more than 153 milligram per deciliter. In the same study, and these result has been drawn on the 1.75 odds ratio. In the same study, fasting plasma glucose cutoff value 89.6, 167.5 after 1 hour of 75 gram glucose, and 140.8 has been found to be a cutoff value for the 2 hour post glucose, found to be having more stringent and more effective with 1.5 odds ratio. And what does the DIPSI say? DIPSI says the same thing. So IAD-PSC, better criteria, more stringent criteria is the similar with the DIPSI criteria. So 1.75 odds ratio on the basis of the composite outcome. That includes primary outcome as well as secondary outcome. But this 140 was based on the purely primary outcomes which were occurring at the odds ratio of 1.5. So definitely this 140 figure is more acceptable than 153. So ACOG has also not, ACOG, the American College of Obs and Gynae, has also not endorsed the IAD-PSC recommendation for the same reasons. And DIPSI has already given you the recommendation of the 140. So diagnostic criteria suggested by ADA, you know this, 95, 180, 155, not acceptable, and IAD-PSC has changed it 95 to 92, but the rest of the two has not been much changed. 180 remained the same, and 2 hour plasma glucose after 75 gram glucose has been reduced only negligible, that was a 2 milligram per deciliter at the 1.75 odds ratio. So fasting plasma glucose has not been found, especially in Asian Indian peoples are concerned, and it has been found to be inadequate to diagnose gestational diabetes. Here, evidence for that. We have got so many studies in which fasting plasma glucose has been tested. The best study which has achieved the best possible results was this one, in which the 92 milligram per deciliter has found to be 3.2% people test positive with the sensitivity of 24% and specificity of 93%. But on another end, this 2 hour 142 after 2 hours of the 75 gram glucose level of the 140 milligram per deciliter have been supported with 13.4% test positive. So you can understand here which is more beneficial, 6% dose in the Hong Kong. And fasting glucose measurement is insufficient for reliably ruling out gestational diabetes. So fasting glucose measurement is really not going to help us in much. Increased insulin resistance during pregnancy in Asian Indian women escalates further in gestational diabetes. So because of that, fasting plasma glucose is not an appropriate option to diagnose GDM in Asian Indian women, as insulin resistance is higher compared to the Caucasian. In all gestational diabetes, fasting plasma glucose value do not reflect the postprandial glucose, which is the hallmark of the gestational diabetes. So if you really want to diagnose the gestational diabetes, fasting plasma glucose is of the least helpful. Of course, this can really help you to find out the patient, those who are suffering with the diabetes but not detected till this time, and they have been first time recognized into the pregnancy. So diagnosis of GDM with 2 hour post glucose more than 140 and treatment is worthwhile with a decreased macrosomia rate, fewer emergency cesarean section and serious perinatal morbidity, and may also improve the women's health related quality life. Randomized controlled trials show the benefit of treating women with GDM who were identified primarily by post-load values instead of those who have been identified by the fasting plasma glucose. There is no high quality evidence that women and their fetuses benefit from treatment if only the fasting value is abnormal. DIPSI guidelines say that the population who has not accepted the GDM treatment, total number have been compared with the 140, and the GDM who has accepted the treatment were the 70 and the GDM not accepted were the 62. In this particular group, which has not accepted the treatment for gestational diabetes as per the diagnostic criteria given by the DIPSI, developed 4.84% stillbirth. Respiratory distress syndrome were not seen in the control group, but it has been seen in the group which has not accepted the GDM treatment. The group which has accepted the GDM treatment has not been found with the respiratory distress syndrome. Similarly, the preterm babies were seen maximum in the people those who have not accepted the GDM treatment. Macrosomia, you can have an idea, 1.4% was also in the control group. It could be reduced with the treatment of the GDM, but while it has been found to be increased in the people those who have not accepted the GDM treatment. The conclusion is that there is an advantage of adhering to DIPSI guidelines in the diagnosis and management of GDM for a significantly positive effect on pregnancy outcome. Neonate birth weight distribution of women with normal glucose tolerance and gestational diabetes. Here you can see that this is the normal glucose tolerance and this is the gestational diabetes. And you can see that the gestational diabetes is not getting good neonatal birth weight outcome as compared with normal glucose tolerance. The birth weight distribution was similar between normal glucose tolerance and GDM women. So GDM status of the pregnant woman after intervention was not associated with macrosomia. So the reason was there for that, because after first trimester, if you are doing anything to prevent or to keep down the blood glucose level, probably it does not affect on the macrosomia outcome. So after intervention was not associated with macrosomia. The single step procedure in the antenatal clinic, a pregnant woman is given a 75 gram oral glucose load, irrespective of whether she is in the fasting or non-fasting state, without regard to the time of the last week. GDM is diagnosed if 2 hour plasma glucose is 140 or more than that milligram per deciliter. One-step test for universal screening has also been accepted by the government authorities too. Supply of the glucometer at the sub-center has been ordered by the government for doing that, and one-step test is feasible as a routine test during the ANC for all pregnant women when National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease and Stroke expands its program to all districts, keeping all the above points in mind as is envisaged in the 12th pipeline. So points of care testing. This points of care testing is the testing with the glucometer. We compare the testing with the glucometer with the testing with the lab. Laboratory test requires complex infrastructure, skilled technician, stable supply of electricity. And all of these are scarce, particularly in non-urban areas. Testing time is more in laboratories, which results in number of women leaving community health centers before diagnosis is established. Point of care testing will have a transformative effect of healthcare. Consideration in testing for hyperglycemia in pregnancy feasibility. The laboratory glucose measurement is often not available, and portable blood glucose meter is the only option in such kind of a situation. So comparison of the venous plasma glucose has been done with the capillary whole blood glucose in the diagnosis of gestational diabetes, and it has been found while doing this glucometer we can have almost equal results of plasma glucose values may be calibrated with the glucometer or it by the laboratory technology. So IRD-PSC requires 3 tests: fasting 1 hour and 2 hours. DIPSI recommends only 1 test, that is the 2 hour only. The difference of prevalence, detection of the prevalence of GDM is 1.2% only. And so it is only 1.2% because of what we have to do the 2 times test more. So discordant pair between the 2 criteria indicated no statistical significance, and thereby implying a close agreement between these 2 diagnostic procedures. The most cost-effective diagnostic tool in less resource community is the DIPSI recommendation to be done 2 hours after 75 gram glucose with the cutoff value recommendation of 140 for the diagnosis and 120 for the management. No difference was found in the prevalence of GDM between previous WHO and IRD-PSC criteria. WHO has recommended 2 hour post glucose more than 140 mg per deciliter, and IRD-PSC criteria, you know this. DIPSI procedure requires 1 blood sample drawn at 2 hours after 75 gram glucose load for estimating plasma glucose. Even if the test is to be repeated in each trimester, the cost in performing the procedure will be 66% less than the cost of performing IRD-PSC recommended procedure. Therefore, DIPSI procedure is feasible, sustainable, cost-effective, and high impact, but best buy for less resource settings. WHO observations and recommendations in 2013, WHO has also accepted this thing, and in its recommendations, it has recommended that in these circumstances, many health services do not test for hyperglycemia in pregnancy because of what there should be preference for the one-time testing. Consequently, non-fasting testing may be the only practical option as per the WHO observations which has come up into the 2013. So earlier WHO was saying that there should be 75 gram glucose testing, which should be in the fasting state, but later on WHO recommendation has come up with a single step procedure to diagnose gestational diabetes at non-fasting state of 75 gram glucose too. Operational guidelines for diagnosing GDM in the community. No screening test is required. Direct diagnostic test with 75 gram oral glucose and measure plasma, 2 hour plasma glucose. This 2-step procedure requiring attendance on 2 separate occasions is often not feasible, so just to avoid that, single step test is preferable. In the first trimester, 12 to 16 weeks is the right time for the screening or diagnosing the gestational diabetes by the DIPSI criteria at the first visit to antenatal checkup. Second trimester, 24 to 28 weeks should be the time when the women should be retested for the gestational diabetes. And 32 to 34 weeks is the third time when she should be tested for gestational diabetes as per the DIPSI criteria. Target blood glucose level should be fasting plasma glucose between 80 to 90, postprandial glucose should be between 120 to 120, and mean plasma glucose should be 95 to 105. Birth weight will come between 2.5 to 3.5 if we are really managing these 3 parameters to be strict. Prevalence of diabetes during pregnancy in women according to their birth weight. It has also been seen the mother, those who have been born as a macrosomia child or as a low birth weight child, they have got the higher incidences of developing diabetes in their pregnancy. So all complicated problems in this universe have a very simple solution. So carry home messages for diagnosis: 2 hour post-glucose plasma glucose value 140 or more than that after 75 gram of the glucose. For the treatment, 2 hour postprandial 120 milligram per deciliter should be the target for all purposes. Estimation of the fasting plasma glucose is not recommended, as fasting plasma glucose will never exceed 90 milligram per deciliter if 2 hour postprandial glucose is less than 120 milligram per deciliter. Elevated postprandial glucose may be more predictive of the potential for fetal morbidity compared with fasting or preprandial values. Therefore, fasting glucose values alone do not predict the need for the pharmacological therapy. Thank you very much. Any clarification, anything you want, I am ready for that.
Dr. Mishra, it was a nice deliberation. Could you tell to the audience any role of glycated hemoglobin at 24 to 26 week?
Yeah. Glycated hemoglobin is very good tool to differentiate between the pre-GDM to the GDM. Pre-gestational diabetes, many a times women do not know about their diabetes status, or they may be in the impaired glucose tolerance while entering into the pregnancy. And when they enter into the pregnancy, then they come to know that they have got the diabetes. So these two groups are very much different in the management. The pre-gestational diabetes requires high level of the insulin, while the gestational diabetes many a time do not even require the insulin treatment. Gestational diabetes, 94% of the gestational diabetes many a time manageable on the medical nutrition therapy. But in the pre-gestational diabetes, this is not at all possible. So it is very much important to differentiate between these two groups. And HbA1c can help us by doing that.
One more point about glycated hemoglobin is
that it correlates directly with the incidence of anomalies in the child. In case you have glycated hemoglobin about 8.5% or low, the anomaly will be somewhere around 5 to 8%. In case it jumps to 10%, the anomaly goes to 25%. So one can prognosticate to the parents as to what is the possible harm your child is going to have. So that is very important about glycated hemoglobin.
For the glycated hemoglobin, actually in India we don't have a standardization of the glycation hemoglobin level. And you can see in your practice also day to day that in some lab you have 6.5, other lab you have 7.5. So in pregnancy, doing glycated hemoglobin level is not very much advisable. In country like India, we don't have any standard glycated hemoglobin level. We don't know exactly what is our population HbA1c level is. So how we will calibrate with it in pregnancy? Same thing happened with the fructosamine level also. Fructosamine level also has been recommended for the GDM, whether the hyperglycemia in last 3 weeks, how much. But we don't have any standard for that. So we don't do, but in 2009, ADA has given one guideline protocol that 6.4 should be the cutoff. But for India, we stick with the FC guideline, which Dr. Anuj has elaborated very much. Thank you.
Does it change any kind of outcome?
HbA1c value? We don't have.
There are few studies are also going on about the HbA1c, in which the people are trying to evaluate the outcome while measuring HbA1c in the first trimester and then comparing with the second trimester and the third trimester. But all these are in the experimental phase. We can come to the conclusion about measuring glycemic status by HbA1c in the pregnancy only after completion and after something concrete comes out of those studies.
But one thing presently we talk about glycemic variabilities as well as along with the A1C levels.
Yeah.
So particularly in the diabetic patients where the there is every chance of glycemic excursions, how it will, the HbA1c would be interpreted as the with the outcome. That's my point.
I'm getting your question. HbA1c is not a correct measure of the glycemic variability. You will agree with me. Because HbA1c really do not reflect the glycemic variability in true perspective, especially glycemic variability status is very high in the pregnancy. Because even in the pregnancy, normally at 1 am to 6 am blood glucose level remains between 55 to 60. So there are the very high chances of getting the hypoglycemia at that time if the night time insulin is a bit higher. Even 1 unit will do the things out of going your hand. So that's why the correct measurement of the glycemic variability in the pregnancy can only be done by the SMBG multiple times. At least 5 to 7 times a day you should go, you should tell your patient to prick herself if she is not ready and she can afford. CGMS would be the answer for that. Then you can go for the CGMS. HbA1c is not taking us to anywhere.
As Dr. Maheshwari has said, the primary role of HbA1c is only to differentiate between pre-gestational and gestational. The moment you differentiate that, then the perspective of fetal outcome totally changes. A fetus escapes anomalies in case it was gestational, because gestational diabetes starts in the second half of pregnancy. Child is already developed. Now, in case you are looking at a patient who has a possible pre-gestational hyperglycemia, when the organogenesis is going on, especially 6 to 8 weeks or 12 weeks, at that time, if the fetus is exposed to hyperglycemia, then you are a worried person. So it can only prognosticate about the child's thing. Don't try to manage glycemic control with HbA1c.
That was my question. That is there
No,
is there A1C
These two are the different things. What you, both of you people are saying, both of you are correct at your own place, but both of these things are different. Sir is saying that it is helpful to tell your patient what is going to be the fate of your forthcoming child. Definitely, at the 12 weeks or 13 weeks, if you measure the HbA1c, if it is 7 or more than 7 or even more than 6.4, you can tell the patient that probably you may be carrying diabetes before entering into the pregnancy and you should go for the all kind of the testing before continuing with this existing pregnancy further. So that whether your child is right or not in every perspective, otherwise it is better to go for the termination of the pregnancy and take another chance for the pregnancy. And what you are saying, that is absolutely different thing. That is for the related to the glycemic variability, and glycemic variability is not measured by the HbA1c exactly, although it gives some idea.
Do you mean to say that as a routine, like doing a 75 gram glucose, postprandial glucose, we should go for HbA1c as a routine in first trimester of pregnancy?
Yeah, good question. At the first trimester, I recommend that every woman should go for the HbA1c to differentiate whether it is now pre-GDM or GDM. Otherwise,
No.
HbA1c is not required.
Madam, first trimester or the first visit, we will test every woman in our country for diabetes. The weight for testing, what he has said, 75 gram postprandial glucose. Whenever the patient comes to me for first visit, I will test her for that. Out of them, I expect about 13-14% will test positive. All those 14% will be tested for HbA1c, not the entire 100. So everyone will not be tested for HbA1c, but those who turn out to be hyperglycemic, those are the ones who could be having glycemia even before pregnancy. I want to find out those. Who are euglycemic, there is no problem.
Here I would like to differ slightly with sir.
I would say one more
In the
thing.
first, just a minute. In the first trimester of the pregnancy, normally glucose level comes
Comes
down.
down, exactly.
So many times, simple glucose measurements is deceiving.
Yes.
You may not have a correct idea whether this
Fasting,
patient...
yes, sir, but not a challenge glucose, not a challenge level.
All-
The challenge level should be positive.
Because...
The criteria for diagnosis in each trimester with challenge is same.
But at the same time, in a normal pregnancy, if the patient is normal, then NGT patients, those patients will reflect the
This, what you are saying, this is for the gestational diabetes. If the person is carrying diabetes before the pregnancy and she does not know about her status of the diabetes and she is entered into the pregnancy, if she is impaired glucose tolerance, as and when she will enter into the pregnancy, she will get her blood glucose level come down.
Exactly.
And you may not get an idea. One of my patient came to me and he said, her husband said me, doctor, coming child is very much lucky for us. My wife has been non-diabetic as the pregnancy has started. Then I told him the whole procedure that this happens because of what you are getting this kind of the result. Don't ever think your wife has become non-diabetic. She is still diabetic, but this blood glucose will start increasing after some time. So just wait and continue checking.
Then what will be in subsequent pregnancies? What's the protocol?
No, we are not yet through with the current expectancy.
I think we'll come to that later. I think we need to give a good round of applause to Dr. Anuj Maheshwari. And we need to conclude this session because we need to go ahead with the other sessions. Okay? So thanks, Dr. Maheshwari. Dr. Barnali Ghosh, and she will be speaking on GDM, obstetric perspective. Dr. Ghosh is known in Calcutta, very much she is practicing consultant obstetrician and gynecologist, a laparoscopic surgeon, and an infertility specialist.